All right, so welcome everyone to the Birds and the BBV Bite for today. My name is Veronica and I work here at the Aboriginal Health Council of WA. And I'm just trying to get there we go. And on the menu today, we have stir fry, which is a mix of a few STIs, mainly notifiable STIs that I'm gonna talk through today. Just to let you know that this session is going to be recorded, so if you can keep your camera on if you want, otherwise, yep, you can turn them off if you don't want to see yourself on the recording, which I hate seeing myself, but I better keep my camera on. I'd like to introduce you to Jo Stan, who works here at ACWA with me, and if you've been to any of the bites before, Jo has presented a couple of times, so thanks for joining me, Jo.
No worries.
Before we start, we would like to acknowledge the traditional custodians whose ancestral lands we gather on today, and that we are on Whadjuk Noongar Boodja. We would like to acknowledge the deep feelings of attachment and the relationship of Aboriginal people to their culture, to their country and to their waterways, and wish to pay our respects to all elders past and present, and pass that respect on to all Aboriginal people that are joining us on this bite today. Okay, so we're going to snack on today. We're going to look at rates of notifiable sexually transmitted infections, and the current rates that I've got actually come from the last epidemiological report from the Sexual Health Bloodborne Virus Program that was actually just put out 31st of March 2022. And if any of you went to the quarterly forum, they presented these rates there, but I thought it would be really good. We all work in sexual health, and it's just a really, good to know what's actually happening in our own areas. So I'll also bring up those rates that are happening in the regions and in the metro as well. We're going to talk a little bit about testing and treatment of these STIs as well. Okay. So there's more people coming in. Welcome to everybody who's also joined us. When you look at STIs and bloodborne viruses and you put them all up on the screen like that, you think, God, there's so many. And the ones we're sort of going to concentrate more on today are going to look at chlamydia, gonorrhoea and syphilis. They are three common notifiable infections. We're going to do a little bit on trichomonas. I know it's not a notifiable infection, however, there are rates, higher rates in some regions of WA, and many of our services actually include trichomonas when they test for chlamydia and gonorrhea. I thought we'll just have a little chat about that one. We're going to look at the current rates of hepatitis B and hepatitis C, and also the rates and what's happening with HIV currently as well. Excuse me. Down the bottom, you can see on the right-hand side that not necessarily considered an STI or a bloodborne virus is thrush and bacterial vaginosis. However, they are two treatable infections that can be actually passed on sexually as well to your partner. So they're mentioned up there on that table as well. If I just get everybody to mute, that would be great. I can just hear a little bit of background noise. Okay, so for the first quarter of 2022, chlamydia rates were 4 times higher amongst the Aboriginal population than the non-Aboriginal population. Gonorrhea was 14 times higher, and syphilis was around 17 times higher. So, it's important to talk about them. It's important that we talk about them with our patients, and it's important that we discuss how important that testing for these sexually transmitted infections is, particularly opportunistically when people present to a service for a non-clinical or a non-sexual reason to be offering testing. And I know that a lot of our AMSs do that so well, and in fact, some services have actually just included STI testing for chronic disease. They popped in STIs, HIV and bloodborne viruses into their pathology for chronic disease as well. And they include them in the 715 health assessment. So there are plenty of opportunities where our Aboriginal medical services are making that time to have those discussions with their patients and offer testing, which is fantastic. Okay, so what's happening with chlamydia? So these are the rates from 2020 to 2022, and chlamydia is fairly steady. So it's the most common notifiable infection, and the rates have remained still, you know, fairly high and haven't really changed, haven't really bumped over COVID either. So it's been, you know, fairly constant along the trajectory for chlamydia.
And is this symptomatic and asymptomatic combined as well?
Yes.
Oh, fantastic.
Yes, that's all notifications of chlamydia.
Interesting.
So if we look at chlamydia notifications by region, you can see there that the metropolitan, of course, being in a larger population, had 8,636 cases of chlamydia notified to March 2022. And then behind that, we've got sort of, you know, the Kimberley, the Southwest, followed by the Goldfields and the Midwest down to the Wheat Belt area. Okay, age groups. So most common age groups for chlamydia infections actually happen between the age of 15 to 35, as you can see there, and the highest rate there in the 20 to 24-year-old age group. Haven't really changed much since the 12 months before. No.
Yeah, it's been pretty steady in terms of the rates as well, and
yeah,
and the change isn't really the same thing. Like you would think that everyone expected that there'd be less STIs for COVID, but of course that wasn't the case.
No.
So it's been pretty steady.
No, probably the most marked increase, if we go to the next slide. Oh, sorry, actually just going back to that slide, was the Pilbara had an 18% increase in chlamydia notifications. So that was sort of the only one that had like a marked increase.
It would be interesting to know whether or not is that an actual increase because there's an increase in transmission, which is an increase in testing. Because like there was maybe it became a health priority in certain arches. So that's I guess that's.
So it'd be good to have those testing rates in comparison, which I don't have.
But that data's not published anyways, so that's sort of kept internally. Yeah,
that's right. So, okay. So if we look at gonorrhea, it's sort of gone up and down a bit between 2020 and 2022. Yeah, you can see there's at the beginning of 20, which was around COVID, we still had those quite high rates. We did do a bit of a drop down at the end of 2020, but yeah, it's sort of been up and down.
Timing wise, that is exactly when sort of COVID became a situation, and also keeping in mind the whole Christmas period, people test a lot less because they don't want to get, and this is something from my experience in sexual health service, people just avoid sexual health testing anytime leading up to Christmas unless it's symptomatic because they just don't have the capacity to manage stuff like that in that period.
Don't
they kind of want to enjoy.
Job.
Exactly. They're kind of enjoying their holidays and their break. So
Okay, so here we go with gonorrhea notifications via regions. Again, a little bit of a drop in the Goldfields from the previous 12 months. Anything else that sort of drop in the Kimberley region? Big drop in the Midwest over this 12 months from 107 to 58. Again, a drop in the Southwest. So sort of overall, there has been a bit of a drop in gonorrhea notifications.
I wonder what the explanation for that would be. Because usually it's not something that it's like you do the test even asymptomatically, right? And I mean, gonorrhea does tend to present more symptomatically than asymptomatically than, say, chlamydia. Okay, chlamydia is a bit
particularly for men. Particularly for men. Men are more. In fact, I've got a slide coming up that'll show that.
Brenda, you've got a question?
Sorry, yes. Can you hear me?
Yeah, Brenda.
Oh, I just wondered with the Goldfields rates, because we did lose a few GPs in town and we lost some key sexual health champions, for lack of a better word. So I wonder
Yeah,
whether that affected our rates of testing. That,
yeah,
could be one. Yeah,
that could be one reason. Yeah,
yeah, could have been one
yeah,
reason. Yes. So,
yeah.
yeah.
Good point. When you get a changeover of staff, you can often see a change in testing, and it can either go up or it can go down, depending on the person you get in the service. Yeah. Okay. Again, gonorrhea notifications, highest rates happening in that 15 to 35-year age group. But then again, look at the 40 to 44, the 35 to 39, you're still getting sort of fairly, fairly good rates of gonorrhea there. I shouldn't say good rates, but you know what I mean.
Yeah. It's good rates though. We love it. We love the positive test, don't we?
Yeah. Oh, I want to show you this slide, even though it's a little bit old, 2019. It was actually from the last annual reports. They're not putting annual reports out so much now because a lot of the staff that were involved in this reporting are actually doing COVID work. So, but this is from the last annual report. These are chlamydia notifications by male and female. So as you can see, the dark blue line is female, the light blue line is male. So there are more notifications of chlamydia in females than there is in males. Look, there could be a few reasons for that. Females, there's more opportunity for testing. For example, they would present to a clinic on average around 4 times a year, and that's actually a research that came out from the Kirby Institute. As a young male may only present once a year. So that could be a reason why females, they're actually tested more. They're tested in antenatally as well. They present to a service for things like periods, contraception. So there's more opportunity to offer a female testing.
I guess I have a question for you as well, V. Would you say maybe females as well may retain chlamydia for a longer period of time? If it's like, say, vaginal chlamydia, than say if it was urethral chlamydia for a male?
I don't know the answer to that question.
The only reason I'm thinking that is because maybe, I don't know, maybe there's just the environment is much more, maybe it's more suitable for that kind of bacterial infection. I'm not really sure.
Yeah, I don't know. That's an interesting point because of the normal flora in the vagina, but I haven't actually seen anything to show that. But I do know that females are tested more. So if they're tested more, then
it's more likely to be
And again, if you have a young man that presents to your service and misses out on being offered a test, then you might not see them for another 12 months. I think that's a good point. But I want to show you this one because gonorrhea is actually the opposite. So you've got more rates of gonorrhea in men than there is in females because gonorrhea is so much more symptomatic. So a male is more likely to know that they have gonorrhea. Their symptoms are, pain when passing, extreme pain when passing urine. They may have a discharge, so they're much more symptomatic than a female.
Interesting. Yeah. I guess going back to the chlamydia point, I guess from my experience with men who have sex with men, right? Yeah. You barely see any chlamydia, urethral chlamydia. Like you rarely see it with men who have sex with men. That's actually our lowest MSM STI. But the highest STI is actually rectal chlamydia. So that's why I was thinking the fact that rectal versus urethral is maybe because the rectal environment is more conducive for chlamydia growth and retention. And some people can have rectal chlamydia for months and it's completely asymptomatic. So it makes me wonder, is there a comparison maybe between rectal and vaginal chlamydia and then there's that increased retention?
Maybe we can.
That's something to look into.
Yeah, we can look into that. Unless anybody online has got anything to add about that who might know. That's okay. Oh, hello, Claire.
Oh no, I was just making the comment that no, I don't think any of us have got anything to add.
No, I didn't. I don't know of anything, but we can certainly maybe investigate that a bit, because there's definitely a lot of stuff coming out about the normal flora within the vagina in relation to STIs and retention of some STIs, because Dr. Wood's daughter-in-law, I think, is working in that area.
Oh, cool.
So we'll do a bit of. All right, I better move on because it's already 12:15. And we're going to do syphilis. So just having a quick look at syphilis. As you know, we're experiencing a syphilis outbreak. It came across from Queensland. They declared an outbreak in 2011. Kimberley declared an outbreak 2014. Since then, we've had an outbreak declared in the Pilbara at the end of 18, I think, in Goldfields. Anyway, it definitely, it's out there. And plus we've got a metro outbreak as well. So that's the regional outbreak. So we have the Kimberley and the Goldfields and the Pilbara region are included in the regional syphilis outbreak. And then we have another outbreak which they've separated from the regional outbreak, and that is the metro and southwest outbreak. So increasing numbers, as you can see, that is from up until 2021. So it's been slowly rising, and as you can see that line there, we've had syphilis rates slowly going up and down, but definitely following that incline. Even during COVID, we had a syphilis outbreak peak, as you can see there.
And it's even like now it's at the highest number ever as of January.
Yeah.
That's good to know.
Yeah. Yeah. And the only reason why it sort of goes down again is that because we actually haven't got any more at the moment.
Yeah.
Fair enough. So this is the number of infectious syphilis notifications in the metro and non-metro of WA by Aboriginality. So from 2014-15 to 2020-21. So the blue line is the Aboriginal notifications of syphilis. So you can see the non-metro there, quite high rates and still rising rates in the metro amongst Aboriginal people. We have 4 really key at-risk groups that we are particularly concerned with increasing rates of syphilis. They are pregnant women, homeless people, Aboriginal people and women of childbearing age. And I know it gets a bit busy, but if you sort of look at the gold line and the dark line, that is the 2020 and 2021 rates. And the grey line at the end are the current rates for the first quarter of 2022.
Can we clarify this is all of WA or is this Perth? Or?
This is all of WA.
Fantastic.
Yeah. No, sorry, this is.
Because I was going to say the numbers seems.
This is Perth.
I was going to say the numbers pretty low as all of WA.
No, it's sorry. This is for Perth. I've got all of WA coming up.
Oh,
apologies.
No,
apologies. Yeah. Syphilis notifications by region and exposure category. So particularly looking at the blue line and the red line. So the blue line is men who have sex with men. So in the metro area, there's been rates of syphilis among men who have sex with men. And again, that sort of stayed fairly, similar. In fact, it's dropped a little bit in the metro area. In the non-metro area, very low rates of syphilis amongst men who have sex with men. The red line is the heterosexual rates, and here are the heterosexual rates for men who have, for the metro area, and then the regional area there. So I don't know if there's any comment I can make on that. Let's see.
The reason that maybe there's the non-metro MSM rates are low, it's not necessarily because it's actually a low transmission, but maybe it's because people are not self-reporting as MSM, or because either from the clinician's end or because the client themselves are not disclosing, because of course increased stigma of being MSM, the more regional you are. So that is just based on, because it's qualitative data, there's obviously there's a bit of bias involved there as well.
Yeah.
Easy to
it's interesting. Yeah. Is there any comments from anybody out there so far?
In terms of the syphilis also decreasing with MSM maybe recently, it doesn't mean that it's probably less MSM transmitting. It's probably the same rate, but if there's a decrease in testing, and I think less MSM are testing now because of PrEP, and PrEP used to be a motivator for people testing every 3 months, and now that there's other ways of taking PrEP, like periodic PrEP, and you only have to test every 6 months, then that also means that people would only be testing every 6 months for sexual health testing. So PrEP was a real motivator, and that's why you saw kind of a spike, especially when PrEP was introduced as a trials in WA, and then when it was introduced onto the PBS. So you could see there was a spike in STIs in general, but that was just because people were testing quite frequently. And then it sort of tapered down because COVID meant less sexual activity, there's less motivations to test, but it doesn't mean that it's not actually transmitting as much. So there's a lot of different factors at play here. So whether or not these are true rates, or is it because it's influenced by behaviour changes in line with testing behaviour changes. Sexual behaviour versus testing behaviour. Yeah,
I know. I guess I do find that interesting that it's so low amongst the non-metro.
But that's just my 2 cents.
But no, that's fine. I think it's important that we, you know, we reflect on those things, and it makes us think then about our practice, and you know, and that goes across the board to just being, you know, more inclusive in our practice as well. Yeah. All right. So, so these are cases of infectious syphilis notifications amongst people living in the regional areas. So this is the Kimberley, Pilbara and Goldfields outbreak, and I know it's a very, very busy slide, but I wanted to just take you to the bottom of the slide to look at the congenital cases, and this is to the 31st of December 2021. So yeah, I think what's, you know, prior to 2014 there had been no infectious syphilis notifications in the Kimberley. Yeah, none at all. Yeah, so I think, you know, when you look at where the Kimberley are now, and think that they didn't have any cases prior to 2014 for that 2-year period, it's really grown. So although these cases are only to the end of December, I do know that for the first quarter of 2022, the Kimberley have had another 27 cases of infectious syphilis. And the Pilbara has had another 50 cases of infectious syphilis, and the Goldfields another 10. So yeah, so there's still cases happening, but obviously people are testing as well, which is fantastic. Okay, this is just looking at the Metro Southwest outbreak, and again, going down to the bottom of the slide, you can see that they've had 4 congenital cases of congenital syphilis and 2 congenital deaths, and that's to the end of 2021. All right, so these are the latest rates that I got from the surveillance data for the first quarter, and there's a breakdown of syphilis notifications there. All right, I wanted to just chat to you about HIV. So what's sort of alarming about HIV for us in that, you know, Aboriginal health sector is that from the 1st of April 2020 to the 31st of March 21, there was 0 cases amongst Aboriginal people. But in the last 12 months, which is the 1st of April 2021, 31st of March 2022, there's been 7 cases of HIV. And I think, you know, although small numbers, it has actually increased the rate between Aboriginal and non-Aboriginal rates of HIV. So Aboriginal people now currently are about 3.6 times at risk of HIV than non-Aboriginal people, and that's really quite alarming. We can also see that there are increasing rates of HIV amongst injecting drug use. And although we haven't got Aboriginal rates of HIV amongst Aboriginal people who inject drugs, what we do know that in Canada back in 2011, in a state called Saskatchewan. They saw the Inuit population, their First Nations people, who had sort of very low rates of HIV for a very long time. And then it got into the injecting drug population in Saskatchewan. And so they just saw this huge peak of rates of HIV happening amongst their Indigenous population. And I think that's what we need to be really mindful of here in Australia, is that once it does get into those injecting drug user populations, it's a really effective way of getting HIV transmitted. So I guess the message is include HIV in STI bloodborne virus testing when you can. Make it a normal thing. In fact, a lot of services now it's an opt-out. So HIV is in there all the time amongst the bloods that they take for syphilis, Hep B, Hep C and HIV. So yeah, I think it's a strong message. Even though they're low rates, we just need to be mindful of that. There's the age groups for HIV rates in the last 12 months. There's more HIV notifications via exposure. So we've had a drop in HIV notifications amongst men who have sex with men, around the same for male heterosexual, a bit of a drop for female heterosexual, but we've had an increase in male and female injecting drug use. So we've just, all those small numbers, we're seeing that little bit of an increase. So I think we just need to be mindful of that. All right, Hep B. So Hep B, I can't believe Hep B with
with all the immunisations we have. Oh my God.
Yeah, but anyway, there's still Hep B notifications. That is newly acquired and unspecified. Yeah, so 28 cases of hepatitis B notifications in the past 12 months. It's a bit lower than the year before, you can see, amongst Aboriginal people. Okay, and there's Hep C notifications, and I know you're doing quite a bit of work on Hep C, Joe.
Yeah, I'm trying to be a bit novel in my approach, and I think what we need to really focus on is promoting needle and syringe exchange programs within Archers and at the community level, because really the only NSEPs that we're seeing are either in the metro area or, say, in hospitals in the regions.
Yeah.
And I think it's better to have more access and more points of service than less. And we do have novel ways of delivering NSEP services, like you've got those needle syringe dispensing machines, or vending machines, but they have fit packs in them. So it's another way, even though you're not having the harm minimization discussion, that's something that you can actually infuse into the packaging of these sort of fit packs. And so that might actually be reduced barriers for people accessing clean equipment. Yeah. So I think services, what I'm trying to do is really work on promoting that these sort of things are possible, that you can be a champion and actually promote. Go to your board, see if you can get an NSEP in your service, because they do work. And if anything, it just shows that you want, as a service, you want to see people of all backgrounds, and that you're not just shutting them out. Yeah, so that's stuff I'm working on.
Yeah, well, we've got a few people from the Goldfields online, and they've got their needle syringe exchange program at the back of their community health, and it works really well.
That's really great.
Yeah. All right, so I guess the key is testing. Sorry, it's a 12:29, I'm going over. So test where you can, every opportunity. Testing for chlamydia and gonorrhea, both, same. Vaginal swab for anyone who has a vagina, self-obtained, can collect themselves, or a urine test. First stream, first part of the stream can be taken any time of the day. If you have a T-Tango machine, you can get a result in 90 minutes. Depending on, if people are having anal sex or oral sex, then you may also think about a self-collected anal swab, so they can do that themselves. Or there's a throat swab for people having oral sex as well. So those conversations are really important, with particularly with gonorrhea. Treatment is very effective. In the Goldfields, Pilbara and the Kimberley, they use the Zap Pack, and in other areas we treat gonorrhea using an injection of ceftriaxone. Remember, if there is any discharge, that it's so important to take swabs, both dry, PCR and culture for MCNS. There's a lot of penicillin-resistant gonorrhea, and so it's so important that we have these swabs so that we can identify that people are being treated correctly. And early treatment prevents complications. So as I said, treatment in those 3 regions that I mentioned still use the Zap Pack. It's about 10 tablets, but absolutely fantastic treatment. Again, contact tracing is really important, and that partners are treated as well, because otherwise reinfection is a huge issue. Yeah.
And we want to break that cycle. So it's that contact tracing combined with celibacy from partners that you've had sex with recently as well, just for the 1 week, and making sure that they test too.
Yeah.
Otherwise the cycle just continues.
It continues, yeah. Sorry, trichomonas, really only a problem in pregnancy. Mainly because it can irritate the bag of waters that the baby is in, and it can cause early rupture of membranes. So particularly in those areas where there are rates of trichomonas, all pregnant women are tested. For those, it can also cause a bit of a smelly discharge, and it's actually the smelly discharge that will bring people to the clinic to get treatment. So, yeah. Again, like any infection, can cause an increased risk of HIV, and that goes with any other STI. Where you have one infection, you are susceptible to other infections. Treatment is just with some like an antibiotic treatment for trichomonas as well. It's an oral treatment. Syphilis treatment, wonderful. We have penicillin. So 1.8 grams or 2 injections of penicillin into each buttock will treat syphilis very, very well. And depending on how long you've had your syphilis, you may need to have more doses of penicillin. We test for syphilis using a blood test, and if anybody presents with a sore of any sort, remember that a swab can be taken as well for PCR to check for syphilis.
Another important thing about that treatment is that it should be also used for contacts of syphilis. So if someone is a contact of someone with infectious syphilis, we should really be promoting prophylactic treatment with the benzodiazepine. And telling them why we would promote that. The reason is it's like you might not turn out positive for a number of weeks, but then you're still infectious, and this is actually the most infectious period when you're not turning out positive. So because you had sex with a confirmed positive syphilis person, we really want you to get onto the treatment now, so that you don't even get that RPR to begin with.
That's right.
So really promote contact.
Because it is about 9 to 90 days before you may show that you actually have syphilis. Like, for example, the top there just shows you some chancres. So, you can be infectious for that time. So that's a really good.
And depending on the bacterial load, some people don't even get chancres. So really, like, you've got some people that are just completely asymptomatic for syphilis, yet still infectious enough through other types of shedding, and not necessarily an actual chancre itself. So and
they can hide as well, and you may not notice them. They're often not painful, but there has been cases of painful chancres as well, because they can also get a bacterial infection in them and can make them really painful. Very infectious at that primary stage, and again the sore can go away, and then perhaps 4 to 6 weeks later you can end up with these other symptoms, which are secondary syphilis, hair loss, the rash, the condylomata lata, those warty growths around the moist areas of your body, you growing your bottom. So people can present at that stage, and they've even found that people are presenting with neurological issues like actually having visual problems or hearing problems, which is something you would have only seen during tertiary syphilis, and they're presenting with that much earlier.
A lot earlier, and it makes you wonder what's going on. Has syphilis sort of mutated in a way that it's become that, like it's become that kind of strain?
Yeah.
Because like it's the same with everything. So yeah, we've definitely seen a lot of more earlier presentations of neurological syphilis. I know I've personally seen one within 3 to 6 months, so nice and early on, when it should be really the secondary phase.
Yeah.
And these damages, these kind of neurological implications can be quite permanent as well. So people can get tinnitus and never get their hearing back to normal again. So there's that too.
Yeah. Yeah. Okay. So so that sort of primary, secondary stage, and that early latent. You are infectious, and you are, if you've had syphilis during that time and you get treated, you will need the penicillin, 2 doses in the buttock, and you probably only need 1. If you've had it for over 2 years, then you'll need 3 injections. So the 2 in your buttock 1 week, and then the next week, and then the following week. So, we don't really see tertiary syphilis so much, which is a good thing.
What I would like to know, I think you'll need to have some sort of expert opinion when it comes to someone who has RHD and then also gets syphilis at the same time, because then if someone's got RHD and is on the secondary prophylaxis for 10 years and then also gets syphilis, like imagine like the treatment regimen sort of needs to line up. Like what would that be involved? Or would that even what would be interesting to know, and I'm sorry, I'm just like having discussion while you're listening, but it'd be interesting to know if RHD, that sort of penicillin treatment, does that have a prophylactic effect on syphilis?
I think we could ask Marianne that. And RHD is rheumatic heart disease. And just remembering that our pregnant women need extra testing during pregnancy. So if you're living in the Kimberley-Pilbara Goldfields, that's 5 tests. First antenatal visit, 28 weeks, 36 weeks, then at birth, and then 6 weeks after. And for the Metro Southwest and other areas, first antenatal visit, 28 weeks and 36 weeks. And that's to prevent congenital syphilis, which we all know is terrible. And it causes stillbirths in up to 1/3 of untreated cases. So, hepatosplenomegaly is the little baby with the big swollen tummy, the skin lesions, and this is Windberger's sign, which is the shortening of the long bones. Hep B treatments. Sorry, I'm moving really fast because I'm worried about the time. Hep B treatments, there's wonderful treatment out there for Hep B, but it's usually people with Hep B only need treating at the times when their Hep B is actually starting to have an effect on the body. So they only need treatment at certain stages of having chronic Hep B. However, it's really, really important that they get tested every 6 months, because then you know what's actually happening with their liver function and whether or not they need treatment. So anybody with chronic Hep B, they need to be tested every 6 months. That's really, really important. We know hepatitis C, there's a fantastic treatment out there that cures Hep C. We just need to make sure that people get tested, because as soon as we find out someone's got Hep C, we can actually commence them on treatments. Wonderful treatment, can take 8 to 12 weeks and you can be cured.
And it's a lot simpler now. It used to be like lots of different treatments depending on the genotype. Now it's just sort of like we don't care about genotype. There's 2 treatments, and it's only by like one's like 3 tablets a day for 8 weeks or 1 tablet a day for 12 weeks. And that's it. That's the only difference. It's to be easy.
And HIV, really, really good treatment.
Oh yeah, 100%.
And then you've got PrEP as well that you can. So I mean, that's a whole session in itself. But again, if we want to get out there and we want to promote HIV testing, we also need to be making sure that we also have that awareness around it's no longer a death sentence. People live as long as anybody else once they're on HIV treatment. The U equals U message, undetectable equals untransmissible. So if you're on your tablets and you're taking them regularly and you're checking your viral load can go down so low that it can't actually be detected, and therefore you can't transmit HIV. And that's such a wonderful thing now for
Yeah, I'm
HIV
glad that that's
positive
become a
people.
worldwide campaign. That's great.
Yeah. So I think that's a really good message, because still a lot of people think that AIDS, you know, people still talk about catching AIDS and, you know, still think it's a death sentence, and it's sort of been that lack of education and awareness. Okay, so test every opportunity you can. Particularly young people aged 15 to 34, make it routine, make it normal. Other opportunities to test. Someone presents for contraception. My God, you would hate to think that someone misses out on an STI test when they're being given contraception. Women who are pregnant or might become pregnant. Change of partner. Men who have sex with men are at high risk. Homeless or couch surfing. We saw those rates, particularly amongst the metro syphilis outbreak. Sex workers, drinkers and drug users more at risk. Anyone with a rash that you can't explain, unexplained arthritis, because we know that gonorrhea can actually go into the bones and cause a gonococcal arthritis. Anyone presenting with unusual cranial nerve palsy, which is a lot of facial drop, or hearing or visual problems, those sorts of things. Look, don't be, it could actually be syphilis, particularly if it's a young person who's never had anything like this happen to them before. Yeah. Asymptomatic testing, as I said, urine swab, bloods. You know, it used to be piss easy, now it's bloody piss easy, because we need to get blood. That's it, guys. I'm sorry I've gone way over time, but I've just put on here the Healthy Sexual, where you can get an online STI screen. So if you've got a printer and computer, you can actually download your own, but it's just for chlamydia and gonorrhea. It doesn't do syphilis, unfortunately. This is where I got all my information from. Love this book. You can now get it because they've just put it up on the Department of Health quick. Yeah, because you couldn't get them for a little while, but they're back up there.
Good.
Yeah,
Good
so I just got a whole box load. Yeah, and there's some more resources there. Oh my God, is there anybody out there who has any questions? I could go to the chat bar, actually. I haven't been to the chat bar.
Love this format. As if joining you and Joe for a conversation. Yeah, we just talk shit. That's what we do. We can bleep that out in the recording.
Oh, look, if there's anybody out there who would really like to come and do a chat, even like a chat with Joe or I or whatever, I would love you to join our bites. You know, it can be just an informal chat, even about what you're doing in your region. I would love that. Yeah.
I agree. I think it's good to have just a nice casual yarn about a topic and just like put it out there, getting the different perspectives. Yeah.
Yeah. All right. Well, thanks very much, guys. Thank you so much for joining us. And same time, same back channel or bite channel next Tuesday, 12 o'clock.
See you, everyone.
See ya.